Welcome to today's ASBC CardioCore lecture series. My name is Dr. Michael Blaha. I'm a professor of cardiovascular medicine and epidemiology at the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. And I'm here today on behalf of the ASPC for an interesting lecture and discussion about risk factors, risk scores, and imaging. And we're pleased to have with us today for this presentation entitled Beyond Traditional Risk Scores, Imaging and Cardiovascular Disease Prevention, today presented by Dharmesh Patel. Dr. Dharmesh Patel is a faculty member at the Stern Cardiovascular Center in Memphis, Tennessee. He serves as director of the Stern Cardiovascular Lipid Clinic and director of cardiac rehabilitation at Baptist DeSoto Hospital in South Haven, Mississippi. He's board certified in 7 disciplines, including the American Board of Clinical Lipidology, and is also a certified clinical hypertension specialist. In addition, he serves as a clinical professor of cardiology at the Baptist University College of Osteopathic Medicine. Dr. Patel is a past national board member of the ASBC. So please join me in welcoming Dr. Dharmesh Patel for today's lecture.
Thank you, Michael, for that kind introduction. I am Dharmesh Patel, cardiologist at the Stern Cardiovascular Center in Memphis, Tennessee. And today's topic, I'm excited to talk about AI-driven plaque quantification, a true paradigm shift in CAD management. You are all aware that the guidelines just changed about a week ago from this recording, or 2 weeks ago. The ACC Guidelines 2026 cholesterol update talked about the fact that certainly we need to use risk evaluation such as the Prevent ASBC score to risk stratify our patients. But I do want to say that, remember, this is a framework for risk stratification. We have to appreciate the fact that people still fall through the cracks. When we talk about the Prevent ASBC risk, we also appreciate the fact that with this risk calculation, less people are eligible for statin therapy. In fact, about 14 million people are less likely to take statin therapy. There are also other pitfalls that can happen with this equation too. For example, there may be minorities that may not be very well represented. And also we did see that there was a difference across healthcare systems in terms of reproducibility. So the point is, yes, the Prevent ASBC score is very, very important, but I just wanted to highlight we still miss people every single day. When I treat patients in my office, I am not treating populations, I'm treating one patient at a time. And I just put on the right-hand side, some of those extra risk factors that we need to consider when we're seeing patients. For example, the enhancing risk factors such as inflammation, such as Lp(a) and ABI less than 0.9 and CRP greater than 2. And then, of course, there are other female or pregnancy-related risk factors that we definitely need to consider in these patients. The purpose of this slide was to simply say that we have to close the gap between prediction and prevention. The Prevent ASBC tool is a good tool, but unfortunately, we still continue to miss patients. And the reason I think this is so interesting is because I think CTA or coronary CTA really has taken progress in leaps and bounds, especially in the last 3 to 4 years. I think a lot of that was triggered when the 2021 AHA chest pain guidelines came out talking about a CTA coronary strategy first, especially for example, patients who are intermediate to high risk, who have stable chest pain and no CVD, and knowing the fact that a CTA strategy first is effective for diagnosis, for risk stratification, and more importantly, for further guiding treatment decisions. So I think, CTA, even in my clinical practice, I've been using a lot more of it recently. And I think one thing I did want to mention, I found this study to be extremely poignant. The fact that this trial, presented at a European Journal Online, talked about the fact that 4.5 million patients who had their first myocardial infarction, 51% of those patients had no documented symptoms. Please appreciate the fact this was a US-based study, and the fact that half the patients didn't have documented symptoms, 1 in 5 of these patients were not seeing a healthcare professional. 2/3 of these patients were not using any kind of preventative medicine. 18% of these patients had no documented SMERVs. What it told me was, is the present calculation tools that we use enough? I really feel that there's an opportunity to bridge the gap between both prediction and prevention. Now, that being said, we certainly have validated data to talk about plaque burden. As we can see here from Neurohamed, the JACC 2023, coronary CTA plaque stage is a better predictor of short and long-term MACE events, more than even the risk scores, your CAC scores, or even the presence of stenosis itself. And I found that to be very, very interesting because, it tells us that total plaque staging is a very important piece of information that we can hopefully be using in our patients in the appropriate clinical setting. And you can see that, it certainly improves your 10-year CVD risk stratification when you do use the plaque staging. This was a very interesting trial study done by Motoyama in 2015, albeit small, but it further highlights the fact that when we do CTAs, there are high-risk plaque features which are very, very important. We know that I'll be showing you in the next few slides some of those plaque features like low attenuation or a napkin ring sign. It has clearly been shown that people that have high risk plaque features, they have up to 12-fold increased risk of acute coronary syndromes. So I do feel that when we're seeing patients, the fact that we can truly personalize their therapy depending on what, for example, a CCTA shows, I think really, really is going to change, I think, the whole approach to cardiovascular medicine. And you can see here with this red circle, the absolute increase in plaque progression when you do have those high-risk plaque features. Now, this is just a graph or a diagram really showing us those high-risk features and those not so high-risk features. We all appreciate that, high density plaque, which is calcified, is associated with lower risk than soft plaque or non-calcified plaque. I always battle with the lady or the female who's like 40 to 45 years old who may have an inflammatory disorder, let's say. I would expect her calcium score to be 0, probably. But I'm always in the back of my mind thinking about, am I truly missing soft plaque? And yes, of course, low density plaque is associated with a higher risk of plaque rupture and clinically adverse events. And then low attenuation plaque, less than 30 Hounsfield units. This plaque is associated with the highest risk of plaque rupture and clinical adverse events. I do want to make sure that we talk about this. When we see patients in our clinics in the hospital, please appreciate 2/3 of cardiovascular events are due to plaque rupture. And that's important because maybe that's the reason why half our patients don't have, quote, chest pain before they actually present with their first myocardial infarction. I feel that plaque rupture is, the sudden acute event, and the mortality of patients who have their first myocardial infarction ranges from about 10 to 20%. That's the number of people. The 1 in 5 doesn't even make it to the hospital. So my challenge, I suppose, in clinic and a discussion we are going to have is how can we better identify patients at risk? How can we personalize their treatment plan? This is just a nice depiction of some of those, quote, high-risk plaque features that we look for when we see patients who've had a CCTA. The positive remodeling that you can see on the top left. On the top right, you have the napkin ring sign for obvious reasons. You can see the soft plaque, and on the bottom left, we have the low attenuation plaque, and then spotty calcifications too. These have all been shown to be identifiers of high risk plaque. And of course, high risk plaque means increased risk of acute coronary syndrome. Now, when you're talking about plaque, the ICONIC trial talked about the fact that non-calcified coronary plaque is the strongest discriminator of risk. You can see on the left-hand side here, when you have calcified plaque or fibrous plaque, this may be plaque, for example, that's got a thick fibrous cap, the propensity to rupture is relatively low. Now, when you look at a patient, let's say who had a fibrofatty plaque or a necrotic core with macrophages and foam cells, you can see these patients have a very heightened risk of a cardiovascular event. This, I think, is a slide that really did open my eyes. And what I mean by that is this trial looked really at total plaque volume, and it talked about the fact that total plaque volume is a strong predictor of myocardial infarction, independent of the cardiovascular risk score, CAC, or even stenosis. Now, they did find that patients who had a total plaque volume greater than 238 millimeters cubed essentially had a seven-fold increased risk of a myocardial infarction. On the right-hand side, we're characterizing low attenuation plaque. Low attenuation plaque presence is the strongest predictor of a myocardial infarction, with about a literally 4.5 to 5-fold increased risk of a myocardial infarction, fatal or non-fatal. So what does it tell me? This tells me that irrelevant of the calcium score, irrelevant of what my risk calculator is, or irrelevant even in fact of how much stenosis there is, total plaque volume is a strong predictor, and also the characterization of the plaque itself also carries weight, such as, for example, a low attenuation plaque. So this was data from the Scott Hart trial. I think it's important to highlight the fact that, plaque is a strong predictor, irrelevant of CV risk, CAC, or stenosis, and low attenuation certainly is a strong predictor of a myocardial infarction. Now, I kind of wanted to talk about being a preventive cardiologist. I think it's also exciting not only talk about, of course, AI imaging, but what do we have in terms of therapies out there? We have certainly trials like the Precise IVUS trial, looking at patients who had lipid-lowering strategy with ezetimibe and atorvastatin. And then we have the GLAGOV data looking at evolocumab and the progression of CAD in patients treated with statin therapy, the EVAPORATE trial with icosahexahl pentyl, and of course then patients treated with evolocumab in statin patients following a myocardial infarction, and then the PAC AMI randomized clinical trial. The reason I think this is important is because if we are going to identify patients, let's say, who have increased risk of a cardiovascular event, let's say they may have a high total plaque volume, or they may have a stenotic lesion which has a high an FFR that's significant. I think it's important to understand what are we going to do about that patient, and also show me the data. So this is where I thought it'd be nice just to show some of the informed therapies that we actually have out there. For example, when you look at the PAC AMI trial, looking at alirocumab added to high intensity statin therapy on patients who have had an acute myocardial infarction, you can see the top row is at baseline, the bottom row is at plaque imaging at 52 weeks. You can see that in this trial, the atherosclerotic volume goes from 62% to 50%. Your lipid core burden index is reduced. And actually, interestingly, you see thickening of the fibrous cap, which to cardiologists like myself would really show stability of that fibrous cap and less propensity to rupture. So carrying on from that prior slide, you can see that patients who had treatment with alirocumab and then were shown to have decrease in plaque atherosclerotic volume, a reduction in lipid core index, and increase in fibrous cap thickness, these patients had certainly improved outcomes in terms of triple regression versus the baseline. So it really shows the fact that, yes, you can reduce plaque atherosclerotic volume, you can reduce your lipid core burden index, and you can cause the plaque to be more stable in terms of thickening of the cap. Hygens is certainly another trial which looked at this in terms of evolocumab in patients with NSTEMI, and you can clearly show here, it, I think, shows again the same message. You have basically an increase in the fibrous cap thickness, which alludes to more stability, and there is a reduction in the lipid arc, which again alludes to more stability. So I think it's important to appreciate we do have data that shows us that we can actually, quote, stabilize plaque. And the EVAPORATE trial was another trial, looking at this, it sought to determine whether, icosahexahl pentyl will reduce plaque progression over 9 to 18 months compared to placebo in statin-treated patients. And I found this to be quite fascinating, because if you look at the patients that were treated with icosahexahl pentyl, you actually did see a 17% reduction change in plaque from the prior scan, reduction in fibrofatty um, plaque formation too. So I found that to be very interesting where, your highest plaque risk features like low attenuation, you can actually negate some of those findings. Now, we are jumping now into the support for AI coronary plaque analysis. I think this is an area which is evolving as we speak. I think it'd be fair to say the last 2 to 3 years in the diagnosis and approach to preventative medicine in terms of cardiology has really changed and is still changing even as we speak today. And I think the guidelines are really embracing some of the quick evolving modalities that are now available to us. For example, the AHA and the Lancet talked about the fact that there should now be an emphasis on early detection of disease with proactive intervention at every stage. We should be more proactive, in my opinion, than reactive, and also appreciating that the prognostic importance of coronary plaque itself. And in medical management, as I've just shown from the prior slides, it shows stabilization and regression. And I think the key point for me is it personalizes preventative therapy when you do have this extra information. Now, ACC talked about among patients who have visual evidence of plaque on coronary CTA, adding qualitative coronary plaque analysis may be useful for enhancing risk assessment and guiding the initiation or intensification of preventative therapies. Ideally, a single report that includes and integrates both coronary CT qualitative and qualitative coronary plaque analysis would be preferable. And serial coronary plaque analysis may be reasonable if it will result in a meaningful change to patient management. So I think the point I'm trying to make is that all the big guidelines appreciate there is a role. I think it just needs to be used appropriately in the appropriate patient setting. So when you talk about plaque burden, I think it's important to appreciate the nomenclature for plaque burden. Stage 1 is 0 to 250 millimeters cubed. Stage 2, moderate plaque, is 250 to 750 millimeters cubed. And severe stage 3 is severe plaque volume. Now, we talk about plaque atheroma volumes. Severe would be greater than 15%, and you can see the different percentages respectively there. So now let's talk about some of the plaque analysis trials. This is one of my favorite trials simply because it's called the Fish and Chips trial, and it's from England, where I'm from, and Liverpool is my soccer team. So I like this trial right off the bat. But more importantly, it studied 2,827 patients stratified according to coronary plaque analysis based on total plaque volume. We saw that patients who had a higher total plaque volume was associated with statistically significant higher CV event rates, even after you adjusted for risk factors like stenosis and FFR. Patients, for example, who had the highest stage plaque volume actually had the highest risk of cardiovascular events. And you can see here in red, patients who had total plaque volume greater than 750 millimeters cubed had a 4.8-fold increased risk of cardiovascular events, independent of other calculations and risk factors. Now, this is a very nice article that came at the American Journal of Preventive Cardiology at the beginning of this year. And it talked about the fact that AI intelligence enabled coronary plaque quantification for personalized risk assessment. How do we get any insights from the Fish and Chips study? And so what I liked about this is they talked about the fact that if we used AI technology and we decided on, depending on the different stage of atheroma, what would be, quote, the projected number of people that would need to be treated to reduce one cardiovascular event. And as you can see quite nicely in this trial or in this graph, patients, 5 years to 4 years who had high stage lipid burden or total plaque volume, the numbers needed to treat became smaller and smaller as time went on. So, at 10 years, NNT of 11 for a patient that had, let's say, stage 4 total plaque volume or a volume of 750 millimeters cubed or higher. I think one point I do want to make that's very important is physiology cannot be assessed by anatomy alone. And this is why I think it's important to have not only anatomy, I think it's important to have physiology, and I think it's important to have total plaque volume too, because you have to appreciate there can be a disconcordance between physiology and anatomy. And what I mean by that is even in a stenosis, let's say that's 50 to 70% stenose, there may be a 1 in 2 disconcordance in terms of is there truly blood flow limiting lesion? If someone has a lesion of 70 to 90%, there can be a 1 in 4 disconcordance in terms of is there truly a stenotic lesion reducing blood flow further. So I do think it's important not just to look at stenosis, but to look at physiology too. You can quite nicely see here patient A and patient B. Patient A, they have plaque volume of 26, which would make them stage 1. Patient B, they have 634 millimeters of plaque volume. But what's really important is if we just honed in and did a calcium score on this patient, maybe the calcium score may not be, quote, that high. But when you actually include both the calcified and non-calcified plaque, for example, in this patient, the total plaque volume is 634, which puts them at stage 3. I mean, that would really change your therapy if you, for example, did not know that he had a lot more, quote, soft plaque. And in his case, or her case, that patient was trajected to the 96th percentile, and their risk increased to 3.6-fold. So I think the advanced DK study is really a nice trial looking at the assessment of plaque and physiology to answer some of these questions. This is basically a prospective trial, 841 patients, and basically looking at the combined information of FFR and plaque analysis together. And so I think what we can appreciate here is the fact that when you look at the graphs and abnormal plaque events, they start occurring at year number 3 in patients who have high total plaque volume. But patients who have high FFR seem to have abnormal events at year number 1. So in summary, patients who had an abnormal FFR appear to have a higher incidence of events at year number 1. Patients who had a high total plaque volume appear to have a higher number of events at year number 3. And when I talk about plaque volume, I'm talking about the top quartile. So really, you really need to look at FFR and total plaque volume together and plaque analysis to really give a true identification of risk. This is a real nice graph showing a patient that basically had fibrofatty plaque and low attenuation plaque. As I mentioned before, that's a patient that increased risk of a cardiovascular and at least 4.8 times more likely to have a myocardial infarction. And I think it'd be fair to say most people would try to start high intensity statin therapy. But when this patient got a serial CTA a year later, you can see here that actually there appears to be progression of disease, both in terms of the fibrofatty plaque and the low attenuation plaque. Now, I think this is where you have to personalize the medicine, and plaque progression was seen and PCSK9 was added. And I think you can see some stabilization of that plaque 4 years from the prior CTA. I just think those are important example of showing what aggressive medical therapy can do above and beyond simply just looking at guidelines. Now, I do like this slide because it talks about what do we know about CTA progression. I think we all appreciate that statins have been shown to cause CTA progression. We certainly have good CV outcome trial data on that. Fish oil capsules, EPA, slowed progression, and we have outcomes data on that. Testosterone, interestingly, it causes progression of atherosclerotic cardiovascular disease, and it seemed to be harmful. And then at the bottom, we have, atorvastatin, which showed regression, and colchicine that may show some mild regression too. And we do have some CV outcome trials with that too. Now, I wanted to change gears and talk about trials that have been done that have shown additive benefit above and beyond simply just getting the a CTA. And what I mean by that is this is a certain trial, about 780 odd patients across 5 US centers, where the CCT analysis was performed, looking at the RAD diagnosis, imaging plan, etc. And I think the point I would like to make here is that when this trial was done, there was basically a 57% change in therapy. There was a 40 odd percent change in stenosis category. There was a 37% reduction in downstream imaging, and so forth. The point is that it appears that this technology or platform is really going to personalize care depending on what we find in that patient. And what I like about it is the fact that we may also avoid unnecessary testing downstream. And when they looked at this trial, the decision confidence was so much higher after this AI platform software was included. So, yes, there was, as I said before, 28% increase in the use of preventive medicines, 30% reduction in the need of further invasive and non-invasive testing, and about a 39% change in the assessment of coronary stenosis. So to me, this information is useful. I think another very, very exciting trial that is coming on board is the DECIDE registry. These are symptomatic patients with suspected CAD who will get a CTA. They will get a plaque analysis. They will be put to a different change in therapy depending on what's found, and then we will further have outcomes on this. Now, this is a trial that is including a multi-center prospective trial in patients, and there's about 20,000 patients that will be studied in this trial. Now, some of that data did come out in Montreal in 2025, and I think it's important to just appreciate what the framework of the trial was. This was actually a collection of preventive cardiologists, CTA experts, based on AI imaging, looking at what would they do depending on the different total plaque volumes. I like this slide a lot simply because I want to make it very clear this is not a quote guideline, but in clinical practice like myself, I'm always looking for ways to further risk stratify. And I want to just make this highlight some of the approaches by this group of experts on how to treat different stages of total plaque volume. And you can see here that, when the total plaque volume is 1 to 100, statins may be reasonable. When you've got a moderate plaque of 100 to 250, getting that LDL less than 70 is reasonable, and you may need to use other therapies. Now, when you get to those severe classes where the plaque volume is 250 to 750 millimeters cubed, and you want to get the LDL potentially less than 55, you may need to go more aggressive. And yes, last but not least, if you do see evidence of inflammation, you may want to consider other therapies such as colchicine and icosahexyl pentyl, icosahexyl. So the point I'm trying to make is this is not a guideline, but a suggested approach from the DECIDE trial on how to treat patients in their study. And so what's interesting is we already have the fact that there was 50% of patients had a change in clinical management within 90 days of the plaque analysis. So I think that's really important. It shows us that maybe the standard of care may not be enough, especially when we have additive information like we do today. And, just as an extrapolation, what would one expect if we do this change in therapy? Well, one would expect a decrease in cardiac risk of nearly 15% if on general you reduce the LDL by about 18 points. This is, I think, what's interesting about the registry thus far. And I want to make it very clear, not all the data is out yet. We don't have the data on, quote, outcomes per se. We don't have really the data on serial imaging, even though we have people that have recommendations. There is no actual, I don't think, guideline on this. But the point is this, it's a huge trial, 20,000 people over 30 centers. And, the AI endpoints for the plaque analysis were staging. And I think what I really learned from this is a third of patients with a calcified plaque of 0 had a change in management compared to CCTA alone. And greater than 50% of patients had medical management change due to the plaque staging. And what is hypothesized is that if the LDL decreases on average by around 18 to 19 points, you would suggest a decrease in cardiovascular events by around 15%. Now, this is interesting. This is a patient that had disease. And you can see here, the first graph, you want to really halt the disease progression. And we all appreciate that we don't like yellow, we don't like soft plaque. We want there to be hardened, stable plaque. And this is just a very nice example of someone who ended up with, total plaque volume at baseline was 260. After therapy, it slightly regressed. What's very important is that if you look at the non-calcified plaque, i.e. the soft plaque, the vulnerable plaque, it went from 140 to 57, a 60% odd reduction. The low density plaque, it went from zero point 0.5 to 0 millimeters, and calcified plaque increased. Of course, this is one of the reasons why we don't repeat calcium scores, but the point being here that with identification of total plaque volume, identifying how much, quote, soft plaque you have and calcified plaque, and then tailoring the therapy to the patient, you can truly show in, for example, a case like this, stabilization of plaque over time. Now, of course, let's not forget that we have talked today about strategies that can hopefully help us further reduce risk in patients who have cardiovascular or plaque. Now, let's not forget, despite all the therapies and all the advances in cardiology, we still have this thing called residual risk. And so I think it's really important that we use the AI technology in the appropriate patient setting. And I'd like to think that some of the information that I gave today really may make you think more about what we can do better moving forward. So I think what's very clear is changes in atherosclerosis are highly correlated with outcomes. And a CCTA now can be used as a non-invasive tool with relatively low cost and low risk. In fact, when you look at the radiation, for example, from a CCTA, it's about 4.1 millisieverts. From a thallium, for example, it's 7.5 millisieverts. And yes, plaque progression can inform patients that current therapies are not sufficient. And for those reasons I showed you earlier, there are frameworks on what we should do depending on what the different stage of plaque volume is. We also appreciate that there can be accurate depiction of stenosis in ischemia assessment with AI raises the confidence and changes management. I think that's fair to say. And plaque imaging and quantification allows for discrete treatment changes. So yes, tracking atherosclerosis affords the patient and the physician the ability to modify treatment plans based on individual responses. And as I said before, when you see patients one at a time, you're not really treating populations at that point. You're really treating patients. You want to personalize and use more precision medicine if you can, depending on the patient that's in front of you in the clinic. I do want to say that Dr. Matt Budoff did help me with some of the slides. I really appreciate him helping me with that. And I really would like to say thank you to all of you for listening to this discussion about quantitative coronary plaque analysis and volume. And of course, I'm from Memphis, so I couldn't say bye-bye without showing some of the people that have come from this great town. So thank you. And I'll give it over to Michael to lead us through the rest of the discussion. Thank you.
Thanks, Dr. Patel, for that educational talk. Slides were beautiful, message was clear, covered a lot of important things about prevention. So I'm sure preventive cardiology and the broad ASPC audience appreciated that talk. So while we wait for additional questions to come in, I wanted to start back kind of at the beginning and ask a couple questions, especially in light of the new 2026 ACC/AHA multi-specialty dyslipidemia guidelines that are just out, right? We have lots
That's
to
right.
talk about. But I want to start back at the beginning of that document, really, when it talks about risk, talks about how we establish risk. And of course, we want to have more of a life course approach, as you talked about. We want to identify risk earlier. And of course, we recognize cardiometabolic risk is more important than ever. And certainly, I know you see that in your practice. And you did make some remarks in the lecture about the prevent risk score. And of course, there's some pros and some cons, like any risk score, but it might be a step forward from where we were before. I'm going to quick give me your reaction again to where the prevent risk score is placed in these new cholesterol guidelines.
Yeah, hi, Michael. Yeah, I think, the prevent risk score, the 2026 guidelines really give us a nice platform to work from. I think the ASBC 10-year risk score is useful. Do not get me wrong. And of course, I think it's most useful, of course, in that intermediate risk, right? We know what to do with low risk. We know generally what to do with high risk patients, but it's that intermediate risk that we're not so sure about. And I think that's where the calcium score has been embraced in the new guidelines, which I'm very, very welcoming of. And, I think the calcium score is a very good tool for asymptomatic patients. The guidelines did say males greater than 40, females greater than 45. I think a calcium score is important, absolutely. And, we know the power of zero. We've heard it so many times. I think what's interesting is, though, there are people that will fall through the cracks. And I'm sure, Michael, you've seen this in your clinic. There are certain patients you have to be careful about. And I'm not saying that everyone should get a CTA. Absolutely not. I'm talking about the fact that those patients who have those enhancing risk factors, things like that high hsCRP, maybe autoinflammatory disorders, ethnicity of South Asian or Filipino, or ABI less than zero point 0.9. The point I want to make is, if, for example, in my practice, I saw let's say a 45-year-old female who had, let's say, inflammatory disorders, there's a chance her calcium score is going to be zero. There's a chance. And, I'm always concerned about, for example, in that patient or even an HIV patient, am I missing soft plaque? So all in all, the Prevent ASBC score is a very, very useful tool. Just like as you said, it's a guideline. And as we see patients one at a time in a room, we use these guidelines, but yes, there are people that are going to be missed. But overall, I think I welcome the fact it uses the calcium score. And I think it's going to be a very good risk stratifier for our patients overall.
Great point. So I want to move to the next part of those guidance before we even get into CTA, which is the calcium score, as you mentioned, which has been elevated to a class 1 indication for a decision aid in selected borderline and intermediate risk patients in whom the decision to treat is unclear. Kind of familiar wording, but elevated to a class 1 recommendation. But for the first time, there's some um, uh, LDL goals that have been set according to the calcium score, right? We now see LDL goes directly from the calcium score, which is new. And it harkens to what we'll talk about in a second, which is the total plaque burden and kind of the treatment of risk, as you talked about with plaque burden. But this is the calcium score, which is a surrogate of plaque burden. So how did you receive these new guidelines about LDL goals as a
I,
function of the calcium score?
Yeah, I think that's very fair and I think it's very valid. We know, for example, even like 10, 20 years ago from the Rotterdam data, that the calcium score is one of the most predictive factors we had, way above blood pressure and hypertension, cholesterol, etc. In fact, obviously it makes common sense. The presence of plaque itself is the strongest predictor of disease. So that was fantastic. Now, I also very much welcome, Michael, the goals, right? High risk goals, intermediate goals. I think we needed these numbers because at the end of the day, no matter what data you look at, even if you looked at, for example, the recent Vesalius data, right? Even in the real world, I mean, only about 18% of patients get their LDL goal less than 70 in diabetics. When you look at the Fourier trial, it was only like 24% of patients actually had an LDL goal less than 55 from that trial. So I welcome the goals because I feel that we need to be using maybe possibly more therapies to get the LDLs to the goals that we need. And I think the days of quote monotherapy for LDL goals is not sustainable. This is no different to diabetes or hypertension, where you would agree we're generally using one, two, or possibly even three therapies to get to that LDL goal.
Yeah, that's great. So yeah, what I really welcomed is then those new guidelines. If the calcium score was above 300, right? There's a
Mhm.
class 1 recommendation to get the LDL below 70, but a class 2A to get the LDL below 55. And if the calcium score is above 1,000, class 1 recommendation to get the LDL below 55. So there's that blending of risk between what we used to call primary and secondary prevention, right? We're getting to secondary
Right.
prevention level LDL goals. And in the guidelines, of course, that these were guidelines that really, in the asymptomatic part of those guidelines, emphasize the calcium score, but they did have a carve out for when CTA could be useful, right? There was a class 2B recommendation for some
Mhm.
particular instances, and you covered those inflammatory conditions, um, FH, certain things where there's a strong recommendation or consideration for a CTA. So, what do you make of the CTA placement in the cholesterol guidelines, and what do you see coming, I guess, with the next iteration after that?
That's a tough one in what's coming. This is evolving so much. I think, Michael, we know, for example, we have three randomized trials that are going to be presented by hopefully 2029, right? We know we're going to have trials on patients who are asymptomatic, who get CCTA, and then their therapy is standard versus change in therapy. And, the trials like the Scott Hart 2 trial will be coming out, the
Right?
Transform trial will be coming out. We'll have even Scandinavian trials coming out by 2029, showing us if truly some of these technologies do actually change outcomes, even in quote, those asymptomatic patients that you were alluding to earlier.
Okay, let's go to some of the questions that are coming in here, some real good ones. Let's start with this one here. And I think we covered a little bit of this, but this is going to take it a little bit further, especially towards the metabolic realm. In the context of prevention, increasingly targeting inflammation, how do you see emerging imaging markers, such as epicardial and paracoronary adipose tissue, for example, compared with systemic biomarkers like CRP, trying to capture this inflammatory risk that we think occurs in and around the coronary arteries?
That's a great question. I think, in my opinion, I think they're all very useful. I don't think it's binary. I think, they are all additive to an extent. There's things like you mentioned, like lipid core index, the fatty index, fatty necrotic index too, that could be considered. And then, of course, you've got inflammation systemic like hsCRP and so forth. All these factors, Michael, in my opinion, are important. I think the key is we all appreciate that atherosclerosis is an inflammatory disorder. And I think we just have to try with therapies that we know that work for hsCRP at this present time to help these patients to quote calm that necrotic core down. And I think you'd agree we we know, for example, those therapies, statins have been shown to reduce hsCRP, bempedoic acid has been shown to reduce hsCRP by 38%. Icosapent pentyl has been shown to reduce hsCRP. So I think inflammation is key. And yes, we have evolving technologies looking at the core necrotic itself and then the surrounding tissues. I think it's going to be all symbiotic in some form or manner.
Okay, I love that. So, okay, another good question that came in. So, do you think that reliance on calcium scores, which some have embraced, some have not, are overused or over-relied on for risk estimation, especially in the new guidelines? This person who wrote this question's concern is that it's become a source of false reassurance, particularly in young patients or people who don't yet know their lipoprotein A, or presumably maybe if their LPA is elevated. So, what do you make of that?
Yeah, I think that the question, Mark, if correct me if I'm wrong, is the calcium score useful in patients who have high PLPA, but the calcium score is zero, for example? Am I right in
I
saying that?
presume so, yeah, because the question's about over-reliance. So probably maybe false reassurance or
Yeah.
quote unquote false reassurance if the score is zero, perhaps.
Yeah, I think that's a good question. We know that LPA itself is an independent risk factor, right, for coronary events. So if I, for example, have a if I have a zero calcium score and the high LPA, I'm always going to drive the LDL down, irrelevant of what the calcium score says. Maybe that's one of the factors where we may go and dig a bit deeper potentially and use CTA. But generally speaking, I have not changed my practice. If, for example, the calcium score is zero, I will generally drive the LDL down as much as possible.
Okay, here's a question. This just come up in the new guidelines. I presume we're talking about calcification here. The question is, if severe or extensive CAD is noted on a regular chest CT, presumably you would see calcification there. I guess the question is, what would you do next? And what tests would be indicated for further risk stratification at that point?
And that's a tough question because that's exactly what happens in practice every single day. CT chest for a smoker, for example, extensive. I saw one today, three vessel coronary calcification. Patient is, quote, asymptomatic. So theoretically, risk stratification would be just involve maybe getting their cholesterol down. Now, I'd be the first to say if I'd be lying to you if I said I'm always going to probably, and someone's got very extensive calcification, not do some kind of functional test. I think because what I know from the first slide I showed today, that up to 51% of patients have no symptoms before their first myocardial infarction. The fact that two-thirds are not taking any lipid-lowering therapies, the fact that 1 in 5 doesn't see a primary care doctor or any kind of doctor, I feel that I would at least do some kind of functional test to make sure that I'm not missing obvious ischemia, because at the end of the day, some patients also will not exert themselves to avoid that ischemia or the angina equivalent.
Okay, good question. So let's get into some more questions about CTA. So I'll kind of give a variation on a question here. Okay, so you've got a patient with some, atypical symptoms, multiple risk factors, maybe family history. Maybe you elect to do a CTA in that patient. Let's say that CTA shows pretty extensive plaque, maybe 750 or 500 millimeters cubed of plaque, like you talked about putting them kind of along the staging profile for aggressive therapy. All right, so in 2026, 2027, 28, we're going to start adding on therapies. When we talk about your choice of therapies for this patient who's got a lot of plaque, and then would you or when would you repeat that CT angiogram?
Good question. So I think it's fair to say, Michael, from what we know from the staging, and that even came out in the 2025 ACC QCPA guidelines, that 750 or more would be considered extensive or severe. So I think the LDL goal, which has been hypothesized, is less than 55, if not less than 40, if you have 750 millimeters cubed of plaque or more. So first of all, you try to drive the LDL down. Now, on top of that, you are going to think, let's say you've given statin therapy after 2 months. It may not be unreasonable to check an HSCRP, for example. You already have done an LPA. But if the HSCRP, for example, was elevated, you may consider other therapies like icosahexaene pentyl. You may even consider colchicine 0.5 milligrams twice a day. So I think what I liked about some of the trials like DECIDE is they've given us a template of how aggressive to be or not to be depending on your total plaque volume. Now, I want to make it clear, it's not a guideline, but it does give you some direction about how aggressive we need to be. Because, Michael, please correct me if I'm wrong, the total plaque volume was a stronger predictor than some of these other things that we use every single day, like the calcium score, like the percentage stenosis. So I do feel that total plaque volume is very important. If that total plaque volume is high or extreme in this case, we should do everything we can to get that LDL to go and potentially even as less lower than 40. I'd like to hear your thoughts on that.
No, I agree, but I want to kick it back to you for this question about repeats. Would you then, in this day and age, and also where we're headed in the field, when would you repeat that to see if the patient says, is that therapy working?
Yeah, Michael, this is the million-dollar question, I feel, because of course, both you and I want to see, quote, how we are doing, but I want to be fair, balanced. The 2025 quantitative coronary plaque analysis paper that was released last year really had no validation of when we should, quote, repeat serial CTAs. There was no validation. However, it said, as I mentioned in the talk, if you had a reason for a meaningful change in therapy, you could consider it. Now, on top of that, we also have to appreciate the fact that we're doing a shabby job on just the simple biomarkers that we have. We can't even get patients to the LDL goal that they have. Forget doing a serial CTA. So, number one, let's get the biomarkers controlled. Number two, you have to appreciate that when you do a serial CCTA, it's important to make sure we reproduce it as much as we can as the prior one. And what I mean by that is the same center, the way AI software, maybe even the same heart rate, even potentially there can be variation in the rate of contrast that you give to the patient, the same vendor. These are all factors that really will be pivotal if you're going to truly compare apples to apples. And then, Michael, the other question is going to be, well, what do you define as plaque progression? Because, what does that mean? And I think, again, we don't have a definitive hard guideline on that, but the 2025 ACC quantitative coronary plaque analysis guideline had given us a suggestion that if you had a greater than a 10 or 20 millimeter cube increase per year, that would be defined as progression. Or if you had a 5 to 10 millimeter increase in a soft non-calcified plaque, that would be defined as progression per year. Again, I want to make it very clear that as of right now, there are no set guidelines. There is no validated outcomes on this quote yet. However, the exciting thing is that I'm sure in the future, we are going to have this information available to us. And what we do know is that when you do these analysis, even if it's for the first time, you have seen clearly that up to 50% of patients have a change in treatment plan, which I think is very, very insightful.
Great, Dinesh. That's a very insightful answer. And I wanted to go to another insightful question from the audience. I think this is getting at a little bit about reproducibility, but I think specifically at the low plaque burden level. So this question says, with increasingly sensitive imaging and increasingly sensitive detection tools like AI algorithms, for example, where we might be detecting subtle atherosclerosis. I think probably what the question refers to there is atherosclerosis, maybe that we can't easily appreciate with our
Mm.
own eyes when we're looking at the study, but there's some detection of early plaque there on the AI protocol. Where do we draw the line between actionable plaque and a indeterminate result? For example, very low plaque burden that maybe is not yet at a threshold for action. That's an interesting area, I think, where people have debated kind of what constitutes plaque in the era of kind of AI detection. So maybe comment a little bit about that in these zero, maybe these calcium score of zero
Yeah.
score patients.
Yeah, so as you said, Michael, I think the question alludes to the fact that sometimes we are, quote, overcalling. And I think that's where the 2025 guidelines talked about. When you're talking about coronary plaque, this has to be, it's going to be an accumulation of lipid or inflammatory cells or something you can visualize, okay? So unless you cannot visualize it with your naked eye, then they're not going to call it coronary plaque because we don't know what it means if we don't see the plaque, yet it is called by AI. So that area is very, very gray. And I think that's what one of the key points of that 2025 paper was is we don't know what it means when you can't see it visually, but the AI is calling it. So I think that area is unknown. I think that's low risk. We want to concentrate on the plaque that we can see and then quantify it with the new CAD-RADS 2.0 scoring system. So I think it's a good question, but there are, of course, always going to be limitations of technology like this. But for right now, as per guidelines, we want to hone in on visualized plaque and staging and so forth from there.
Excellent. Excellent. Okay. Dharmesh, I got another question for you that I'll adapt from one of our viewers here. They've read the guidelines. They saw these LDL goals based on the calcium score. And they say, well, okay, let's say you don't have a calcium score. You have done CT angiography and you've got your total black volume. Um, and I think maybe this gets at the stages, but I'll let you kind of comment on that. How can we extrapolate or translate those new guidelines on the calcium score and the LDL goals to CT angiography and plaque volumes? In other
Mm.
words, kind of can we map the calcium score recommendations on top of total plaque volume kind of things in sort of a similar way that you talked about
Yeah.
the staging?
Yeah, I think it's a good question. I think I'd take the information from my calcium score and I'll look at the guidelines and try to get to those appropriate goals. But let's say my CTA comes back and the total plaque volume unexpectedly is, let's say, a lot higher. That's going to change my quote LDL goal. So what am I saying? I'm saying that if I was to get the total plaque volume and it was quite high, I would veer on the goal of that staging of total plaque volume over the calcium score more in that scenario because I think plaque burden does trump. And so I suppose whichever scan gives me the most reasoning to lower the LDL is the one I will go with, I think.
Okay, great. So let me make a comment here for the audience here because we do have a survey we want you to fill out. I'm going to comment on that while we take our last question. Um, so as we've turned to the last question, take a moment to click the survey link in the chat box to go ahead and complete this short survey because that feedback helps us make these future CardioCore lectures even better and make sure we get all the right content that you all are looking for. So let's look at a final question here. So Darius, this has been fantastic. So thought-provoking. A look into the future, a look into the present, but a look into the future too. Okay, so let's maybe speak to the folks out there who are saying, well, I don't use CT angiography as much yet, but I want to use it more. We're looking to maybe build or use a vendor out there who uses AI plaque quantification. I'm trying to build a program around this, build a prevention program and build a CTA program in 2026 and beyond. What advice do you have out there for the prevention folks out in the community, maybe, or trying to build that prevention program that really is going to be imaging based?
Yeah, I think we can all appreciate that at this present time, what CTA does is basically it gives you a non-invasive biopsy of the coronary vessel. And I think that as long as the software and your platform you're using are reproducible, safe, you have excellent data behind that, um, good studies, guideline driven, I think that's the key. And so I'm going to say that the group that does embrace CTAs or CTA of quantitative plaque analysis is going to be the winner because at the end of the day, the patients will benefit. I have so many stories, Michael, I'm sure you have too, where you've done the calcium score, you've done the calcium score just slightly abnormal, and you've done further testing and you found out the plaque volume, and then you've realized that you've changed your therapy or potentially even gone to do an intervention. I think it's going to change the way we approach cardiovascular medicine because there is nothing stronger, in my opinion, than the presence of plaque itself. And now that we have technologies and platforms where we can even consider staging the stents, we even have, the consideration of maybe even doing balloon angioplasties to neutralize the risk on maybe lesions, and then maybe doing aggressive therapy thereafter. These are all exciting times right now. And, I just think we're at the beginning of personalized precision cardiovascular preventative care.
Oh, that's exciting, where we all want to be. Can't wait for even more data to roll in to support this evolving field. But clearly, where we're headed is imaging, better risk prediction tools, and targeted, LDL or blood pressure, you name it, LPA goals according to the risk of the patient. So I just wanted to say thank you to you, Dharmesh.
Oh, thank you,
Great talk.
Michael.
Thank you to the audience for joining us. Thank you to the ASPC for putting on this wonderful lecture. And thanks to our audience who have probably engaged in preventive cardiology all day today and wanted to learn a little bit more before their end of their day. So once again, thank you all for joining. Thank you to Dr. Patel. Thank you to the ASPC.
Thank you very much. Have a good evening.